Good morning. Okay, this is a continuation of chapter 12. We are going to be discussing the upper gastrointestinal system, and we will begin on page 454 in your book. All right, let me figure out how to make this smaller so that you can see. All right, so this is a frontal view of the stomach. Now, for an upper GI, what happens is you will actually look at the distal esophagus, the entire stomach, and the first portion of the small intestine, which is the duodenum. So when you look at the stomach from the front, you can see where the esophagus comes down. Hang on one second. You can see right here where the esophagus comes down into the stomach. And then you've got all the portions of the stomach. The fundus, which is the upper portion that actually sits the most superior, and actually in the next picture we'll look at a few pictures down, it sits the most posterior. Then you've got the body, which is all in the middle, and then you've got the pylorus, and then that dumps into the first section of the small intestine, which is the duodenum. When you look at this all labeled, you can see where you've got the esophagogastric junction, where it comes through, the esophagus dumps into the stomach. And then, like I said, we've got the fundus, which is the air-filled, in this particular picture, it sits the most superior. Then you've got the entire body of the stomach with the greater and lesser curvature. And then you've got the pylorus portion of the stomach, which is the end where it dumps into the duodenum. Now, when we look at a picture of a barium-filled stomach and duodenum, notice you can see air is actually in the fundus, because we talked about before that gastric bubble, that there's always air in the stomach from us talking, chewing gum, potentially smoking, eating. We just always tend to swallow air. So whenever the person is upright, they tend to have an air fluid level in the stomach. Even if there's no food, you will always see the gastric bubble up here in the fundus. You can see the body is full of barium, which is a radiopaque positive contrast media. You can see the greater and lesser curvature, the pylorus, and then it goes into the duodenal bulb and into the duodenum, which then leads into the jejunum and through the rest of the small intestine. Now, when we talk about the orientation of the stomach, you can see on page 455, they show you these pictures where from the front, it's what we discussed, the fundus, the body, and the pylorus, and then it goes into the C-shaped duodenum. But when you look at it laterally, and you notice here's the spine right here, that the fundus not only sits the most superior, but it also sits the furthest back. It's the most posterior portion of the stomach, and that's important when we talk about positioning, knowing where the barium distribution actually is, because the barium will actually, when the patient is supine, the barium will fill the fundus and it will fall backwards, and you're able to visualize that. So if you do an image and you're not sure which one it is, you have to look at the orientation of the barium. So they tell us that the fundus is the most posterior. It's also the most superior. The body is anterior and inferior to the fundus, and the pylorus is posterior and distal to the body. Now, when we talk about air and barium distribution, notice in this picture, which is at the bottom of 455, that the black represents air and the white represents the stomach. So when the patient is on their back or supine, since this is the most superior and posterior portion, what actually happens is it fills with the barium and it drops back. And then the body and the pylorus actually are full of air when the patient is on their back. When the patient flips over onto their stomach or prone, everything switches. So now the fundus, which is the most posterior, but when you're lying on your stomach, it would actually be up, is full of air, and the body and the pylorus are actually full of barium. And when the patient is erect, like I said, air rises, fluid falls, and you get this distinct air fluid level in the stomach where you can visualize air rising to the top of the stomach in the fundus, and then you've got fluid falling in the body and the pylorus. All right, and if we correlate that to looking at this image and we ask which one was taken PA or prone and which one was supine, you have to look at the orientation of the barium versus air. So in this one, we see air all up in the fundus, and we have barium in the body and in the pylorus. You can see the rugae, the little folds in the stomach that allow for expansion. So if air is in the fundus, and we know the fundus sits the most superior and posterior, then the only way for that to have air would be if the patient is lying on their stomach. Whereas when the patient's lying on their back, notice that the fundus fills with barium and the body and the pylorus are full of air, which means the patient is lying on their back because this would be the most superior and posterior portion, which means all the barium will fill the fundus in the back. And then you can see an outline of the barium around the edges of the stomach. You've got the body, the pylorus, and then it goes into the duodenum. And then you can see it coming over here into the jejunum, which we've talked about has a feathery appearance from all the villi. All right, so we were absolutely correct in that the patient is supine in this one because there was barium filling the fundus, air in the body and pylorus, and then they were prone in this one because there's air in the fundus and barium in the body and the pylorus. So knowing that distribution, let's go back, knowing that air fluid distribution and the orientation of barium versus air is important when you're trying to visualize what image you actually took. Now, while we're looking at this picture, and it doesn't really have to be this picture, we can actually go back. I just want to talk about two weight loss surgeries that are very common for the stomach, and we actually take part in imaging some of this, and this is not in your book, but the two surgeries that they do for weight loss, one is a gastric bypass, and the other is called a lap band or a lap sleeve, lap, L-A-P, which means laparoscopic. When they do a gastric bypass, they actually reposition there's actually cutting and repositioning of the esophagus and the stomach, and they kind of bypass the stomach so that there's not as much room for the patient to ingest food. Now, gastric bypass is usually a pretty dangerous surgery because of the positioning and the repositioning, and patients don't often, patients do well with it, but it's a risky procedure. The more common thing that they seem to do now is called a lap sleeve, where they actually put a sleeve over the stomach. They kind of wrap it almost in mesh, and they tighten it by filling saline in the little mesh around it. And what it does is it compresses the stomach or makes it smaller so that when you eat, the patient would feel full faster, and then that would promote weight loss. And the nice thing about that is when they get to their desired weight, they can actually come back in, and under fluoroscopic guidance, they can take some of the saline out to allow the stomach to expand so that they can eat a little bit more. So these patients, these bariatric patients, often will come into the radiology department, and under fluoroscopic guidance, we will watch as the radiologist or the fluoroscopist instills saline to either compress the stomach so that they can increase the weight loss, or allows for expansion by removing some of that saline so that they can eat more. Interesting if you ever get to be in on one, kind of interesting to watch. All right, let's go back to, now we're going to go from the stomach into the duodenum, okay? And this is on 456. We've talked about the fact before that the duodenum is the shortest segment of the small intestine. It's only about 10 inches, but it is also the widest portion of the small intestine. It does form a C loop like we've discussed before. You can see this C shape here. And remember, we said that it kind of hugs the head of the pancreas here in that C loop, and they reference that as the romance of the abdomen. And the duodenum does sit retroperitoneal or behind the peritoneal cavity. We talked about some of those things where what sits anterior, or what sits intraperitoneal, what sits infraperitoneal, and what sits retroperitoneal. So the duodenum is actually retroperitoneal, C-shaped, smallest segment. They don't even really, as far as, 2/5, 3/5, they don't even give this an amount because they say it is so short. The small intestine, you remember we talked about, is roughly 15 to 18 feet in length. So because of that, that 10 inches doesn't really make up a significant portion. Now the duodenum has different parts. You have the pylorus of the stomach, where it ends and dumps into the duodenal bulb or the duodenal cap right here. And then you've got the superior portion of the duodenum, the descending portion. Now the descending portion is important to us because this is where bile, either coming from the liver or from the gallbladder, is dumped in here, as well as the pancreatic duct dumps the pancreatic enzymes in the descending portion of the duodenum to aid with digestion. And we actually do an exam. It's called an ERCP, an endoscopic retrograde cholangiopancreatography. I know that's a mouthful. That's why we call it ERCP, where we actually use a scope, and the radiologist feeds the scope, or the gastroenterologist, and we look into this portion right here where it dumps in, and we check for stones or strictures. Then you've got the third portion, which is the horizontal portion, and then you've got the last, which is the ascending portion, and that dumps into the jejunum, which is the feathery portion of the small intestine. Okay, let's see. All right, moving on. When we look at this next picture, as far as reviewing, they're asking what is this position. So when we look at this, we notice that there is air in the fundus, barium in the body, and the pylorus. So in order for there to be air in the fundus, this has to be a PA, or a prone position. All right, and then you can quiz yourself on 456 for all the different parts of, got the distal esophagus, you've got B, which is the esophagogastric junction, and then you feed into the fundus and all the parts of the stomach leading into the small intestine. All right, when they talk about digestion, there is mechanical digestion and chemical digestion. So when they talk about the mechanical digestion, it starts in the oral cavity. And you've got two terms that I want to make sure you're aware of, which are mastication, which is chewing, and deglutition, which is swallowing. So in the pharynx, typically the oropharynx and laryngopharynx, you've got deglutition. When you swallow, it goes down your pharynx into the esophagus. And the esophagus, once you swallow, remember we said that fluids tend to pass in about 1 second, 1 second, primarily by gravity. Solids pass in 4 to 8 seconds, typically by gravity and peristalsis. Now, why do we say gravity? Because I don't know about you, but when you eat or drink, it's much easier to eat or drink if you're upright. If you've ever tried laying on the couch and drinking, you can do it, but it's not as comfortable. It's a lot easier if you're upright, or at least your thorax is upright, because gravity helps to pull it down. Now, once you leave the esophagus, it goes into the stomach, where it's there for about 2 to 6 hours, depending on your metabolism. And this is where there's a mixing and peristalsis, which is the alternating waves of contraction and dilatation that move the food through. And this is where it becomes chyme, is in the stomach. All the acids and everything work on that. Once it leaves the stomach, it goes into the small intestine, where it spends 3 to 5 hours. And this is where you have rhythmic segmentation, or churning, taking place, as well as peristalsis, which moves the food through. Now, when they talk about the 3 primary functions of the digestive system, you have ingestion, which is where you take the food in, and or digestion, which begins in the oral cavity, and then it goes to the pharynx, the esophagus, the stomach. And then once you get to the small intestine, that's pretty much where a lot of your absorption takes place. Um, in the small intestine, you absorb a lot of your minerals. You absorb a lot of your I just drew a blank. I'm sorry. That's where you absorb a lot of the nutrients that we need. Okay, now some does take place in the stomach, but most of it takes place in the small intestine. And then the main purpose of the large intestine, that's where the water is reabsorbed and you actually form the fecal material. And the main function of the large intestine is to eliminate feces. All right, the main purpose of the small intestine is where you actually absorption. When patients have malabsorption system, oh my goodness, malabsorption syndrome, it's where they don't absorb things very well. A lot of times we can image based on whether it takes forever for their food to pass through, or sometimes patients will say food goes right through them. They eat and they're immediately in the bathroom. Those are some reasons where we actually do imaging of the small intestines. Body habitus, we've discussed this. Now, the orientation of the stomach and the intestines and the lungs is completely different when we move from one body habitus to the next. We talk about the fact that when a patient's hyperstenic, they're wider, so things tend to spread out. So the large intestine spreads out around the periphery of the abdomen. Your stomach sits almost horizontal. The diaphragm is much wider, and the lungs are short but broad. Compared to an astenic patient where you've got quite a significant arc in the diaphragm, you've got long, narrow lungs, a severe J hook to the stomach, and the intestines are still on the outside, but notice there's quite a dip or quite a drop in the flexibility of them. So we also have said that not every patient fits nice and neat into one category, and it's very subjective. What you might call hyperstenic, I might call stenic. Still important to note when we're trying to image evaluating those patients. So hyperstenic, we said stomach sits high and transverse. The duodenal bulb and the gallbladder are at about the level of T11, T12, and the large intestine is widely distributed from side to side versus a stenic and a hypostenic. Stenic patients have a J-shaped stomach, whereas a hypo or astenic has a significant J shape to it. And then you can see where a hyperstenic sits at T11, T12, a stenic patient is roughly L1, L2, and hypostenic, it drops to L3, L4. And the large intestine is much lower in that type of patient. And they just reiterate that again. This is all on page 458. And it's important to note where that is, because that's why I keep stressing to you guys about knowing your anatomy. When you're looking at the fluoro screen, when the radiologist or the fluoroscopist is taking images, you need to make note of, are you looking more at the thoracic spine? Are you in the lumbar spine? Like, what anatomy are you seeing? Because that is absolutely going to help you with your positioning. Fluoro is like a peek into the person before you actually have to take your overhead images. So absolutely vital that we look at the screen and see what's going on. Now, they also show us, we've seen this picture before when I passed my book around, I think in intro. They show you the different body habitus in real people, and then they show you how their stomach orientation would be. Like we said, a hyperstenic patient, more high and transverse stomach. Stenic patient, J-shaped. Hypo or astenic, significantly J-shaped on that patient. And like we said, where the duodenal bulb sits, T11, T12, L1, L2, L3, L4. So realize that the narrower the patient gets, the more everything drops, because there's not as much room for it to spread out. An upper GI. Now this procedure, when we do this upper GI, we're looking at the upper gastrointestinal system. So we do need contrast media, because if we look at just an AP abdomen, we've talked before that this patient absolutely has a stomach, has a duodenum, an entire small intestine, large intestine, everything is in there, but because it has the same density, like mass, density, MASS, everything looks the same. It looks homogeneous in there. So the only way to make anatomy stand out when it's a hollow piece of anatomy is to actually place contrast media in there so that you can visualize the stomach and the intestines, or the large intestine, the gallbladder, whatever we need to visualize. We have to put contrast media in there. And remember, by definition, contrast is a visible difference between brightnesses or exposures. So the only way that we see this stomach is to put something in it that kind of outlines or highlights that. Does this patient have a stomach? Absolutely. You just can't visualize it because you've got nothing in there to make it stand out. Now, with an upper GI, we can do either a single contrast upper GI, which is just barium, which is our positive contrast media, our radiopaque contrast media, or we could do a double contrast upper GI. Utilize barium, which is positive or radiopaque, and air or carbon dioxide. The carbon dioxide are little fizzy crystals that actually, they're almost like pop rocks. They pop and they produce air inside the patient, or they could just swallow room air. But what you get is an effect of, you've got barium and then you've got air distribution as well, which kind of forces the barium along the edges and allows you to see through the organ, versus if you just have barium, you're not able to see through it. It's kind of all blocked with the barium. Depends on what they're looking for as to which exam gets ordered. When we look at a double contrast upper GI, you can kind of see on here, this is the fundus full of barium. So I'm assuming the patient is supine because there's not an air fluid level and the fundus is full. And then you can see all the rugae in the stomach, because typically for this exam, the patient is NPO, which means their stomach is empty. And you can see all the little mucosal folds in the stomach that line with barium. And this allows for expansion so that when the patient eats, the stomach can expand to hold the contents. All right, what are our duties when we do an upper GI? We have to prepare the fluoroscopy room, prepare the contrast media, get a clinical history on the patient, and explain the procedure to the patient. Now, like I've said before, this is not any different than anything else we do, because we always have to prep the room. We have to get anything we need necessary ready. We always have to get a clinical history, and we absolutely should explain the procedure to the patient. Now, when you explain the procedure to the patient, you don't want it to be a highly technical, involved explanation. You just kind of want to basically tell them what we're going to do today. We're going to take one image of your abdomen before we start, which is a scout image. Remember, that scout image is to take an image of the abdomen before you actually give them contrast media. So if we go back for a second. On this slide, this might be your scout abdomen. Now, granted, they clipped the pubic symphysis, which is definitely something we need, but you take one image before you start, because once you put that contrast in, there's no way to see what it looked like before until they empty that out. All right, now, let me go back to where we were. So we explain the procedure to the patient. We're going to get one image of your abdomen to see what everything looks like before we start. Then the radiologist is going to come in. They're probably going to have you drink some barium and have you moving around on the table, take some pictures of you, and then once they're done, we're going to get some additional pictures on you. Once all that is done, we'll go ahead and get you dressed and we'll let you go ahead and leave. Just like with any fluoroscopy procedure, you have to introduce and assist the fluoroscopist. You want to introduce the patient and the fluoroscopist, whether it's a radiologist or an RA, whoever happens to be doing the procedure, you want to introduce the two. And our job is to always assist the patient, okay? For the upper GI, it actually starts just like the esophagram. The table is upright. Patient stands on the footboard, and they're in an erect LPO position. The barium is also in their left hand so that there's no obstruction of anatomy. Why do we do an upper GI? Some of the indications for an upper GI would be if the patient had a peptic ulcer or a hiatal hernia, or maybe they have diverticulum, gastritis, and inflammation of the stomach. They might have a tumor. They might have a bezoar. A bezoar is basically like a human hairball. I know that sounds funny. There's different types. There's a phytobezoar and there's trichobezoars, and those are actually in your pathologies. Kind of interesting to read about. One comes from plant and vegetable fibers. The other one tends to come from, oh, I just totally lost my train of thought. I'm so sorry. I'm trying to flip around here. The phytobezoar is ingested vegetable fibers or seeds. A trichobezoar is actually made up of ingested hair. So you know how sometimes little kids get nervous and they chew their hair? They can actually cause a bezoar, like a hairball in their stomach. And if you look on page 471, there's actually an image in 12.72 of a trichobezoar, which is huge. I saw a program once where they removed a trichobezoar from a patient whose nervous habit was to chew her hair, and she actually had a 40-pound trichobezoar in her stomach. It was disgusting. All right. This is that picture of that. So this entire thing, not the 40-pound one, this is another one in the book. This is a huge hairball. But unlike a cat, I don't think the patient's going to be able to cough that up. So it typically has to be surgically removed. Over here, you've got a duodenal diverticulum. Remember, a diverticulum is an outpouching of the intestinal wall. So you've got fundus up here, body, the pylorus, and then it goes into the duodenum. And right here, you've got a big diverticulum of the duodenum, which means it's got an outpouching of it so that food could get stuck in there, fluid could get stuck in there. Just any weakening in that wall causes a diverticulum, which is sometimes uncomfortable for the patient, can sometimes cause some issues with their passing of food. A sliding hiatal hernia, again, this is part of your pathologies. This is caused by a weakening of the esophageal sphincter, which is between the esophagus and the diaphragm. The purpose of that sphincter is to keep the cardiac portion of the stomach below the diaphragm and not allow esophageal reflux. But what happens is sometimes that the top portion of the stomach can actually slide through that diaphragmatic opening. Okay, a lot of times it's at birth, but it's usually present at birth, but it doesn't usually cause issue until the patient is a young adult. It says a sliding hiatal hernia can produce a radiographic sign, which is called the Schatzky ring, which is a ring of actually mucosal tissue that lines the esophagus that protrudes into the lumen of the esophagus, and they've got it pointed out right here. That little ring on there, that's indicative of a sliding hiatal hernia. So you can see here, this is a portion of the distal esophagus. This would be the beginning of the stomach, but notice that the diaphragm is all the way down here. So the stomach has actually protruded up through the diaphragm, which is extremely uncomfortable for the patient. Sometimes when you see a sliding hiatal hernia, if the patient is actually lying supine on the table and you were to place the table slightly Trendelenburg or head down, you can actually watch the fundus of the stomach slide through the opening, and then if you put the table back down, a lot of times it'll go back down. So again, not comfortable for the patient. Gastritis is an inflammation of the lining of the stomach. You've got that thickened rugae folds in there. Again, not really comfortable on the patient. Gastritis, remember, itis is an inflammation. Gastro refers to the stomach, so it's an inflammation in the stomach. Patients don't really, just painful from that. A lot of times, if it's acute, then there's severe symptoms of pain and a lot of discomfort. But if it's chronic, then it kind of comes and goes. Sometimes diet changes can bring it on, stress brings it on, but you've got thickening of those rugal folds throughout the entire stomach. And then what they're trying to show you in picture B, like you see all these rugae over here, which are thickened. Over here you see some of the rugae, but then you've actually got no rugae in this section. So again, if there's no rugae, there's no room for expansion, which could cause pain or discomfort for the patient. All right, positioning. Now this is going to be positioning for the upper GI. We discussed esophagram positioning in the last lecture. So for an upper GI, the patient is actually NPO 8 hours prior to the study. Now NPO, remember that means non per os, or nothing by mouth. So the patient can have nothing to eat or drink, and there's also no gum chewing or no smoking, because both of those things, eating, drinking, gum chewing, and smoking, can introduce air into the stomach, and that is not what we want when we're doing this procedure. Even if it's a double contrast study, you don't want to start with air in the stomach because it's hard to get the barium to displace the air. So nothing by mouth for at least 8 hours prior to the study. Longer is preferred, and that's typically the case, but minimum of 8 hours. And remember, you're going to be taking a scout image, so you'll be able to see what the stomach looks like before you actually start, and the radiologist or the fluoroscopist actually has to clear that image before the procedure begins. As always, we want to determine if there's any chance of pregnancy before we begin the procedure. As far as the room prep, again, the patient starts in an erect position, standing on the footboard, and they're actually in an erect LPO when they start. And the barium would be in her left hand over there. The fluoroscopist or the radiologist is going to give her some barium to drink, have her moving around on the table, watching on the screen, and then at some point the table will lay down. They'll have them rolling around as well to kind of coat the stomach and look at everything. Our biggest job is to assist both the fluoroscopist and the patient. When they talk about the 4-part summary of positioning and tips for an upper GI, getting the clinical history, reviewing that with the patient and documenting things. Their body habitus absolutely affects the positioning. Fluoroscopy, when the fluoro is going on, you want to identify any positioning landmarks to help you with your overheads. And we always use a high KVP and a short exposure time. Okay, typically between 100 and 125 for single contrast studies, and typically between 90 and 100 for a double contrast procedure, because when you have air, you don't need as much penetrability of the beam. And you always want to try and control any voluntary motion. Remember, voluntary is under the control of the patient, so breathing, moving, things like that. Involuntary motion would be things like heartbeat, peristalsis. For an upper GI, we actually do 4 views are your routine, and they're all necessary. We talked about with the esophagram, there's 4 views, but only 2 are the most diagnostic and 2 aren't very diagnostic. So on the upper GI, we tend to go in this order. We do AP, an LPO, an RAO, and a right lateral. Those are our 4 images. So when we start with an AP upper GI, you can see that the patient is lying on their back. The image receptor is actually underneath. Now this is, if it's a retrofitted system, you would have an IR in the bucky. If it was direct radiography, you wouldn't see that, but you would know that it was under there. And this positioning is actually on page 4. This positioning is on It's weird. It's the last page in the chapter on 486. Okay, so in AP upper GI, you want to make sure the patient's lying flat on their back and that there's no rotation. The central ray, it says, is to the level of L1, which I'll explain in just a minute. Now, when we do this, you can see this little inset picture up here. The patient's in a Trendelenburg position. That actually can demonstrate a sliding hiatal hernia. When the patient lays like that, the stomach, because it's got barium in it, is actually very heavy, and it can slide up through that diaphragmatic opening. Even in their normal orientation, you're going to be able to see different pathologies with these overhead images. So you've already taken a scout on this patient. The patient's already had the radiologist or fluoroscopist come in, and the patient's drank barium. And now they're not drinking any more barium, but we're getting some additional images on them. So the patient lies on their back, ideally fit on a 14 by 17 lengthwise, and that would be patients. No patient's stomach should be bigger than that. Even large patients don't have stomachs that would exceed that IR size. The technique for this, if it's a single contrast study, is 110 kVp at 2 mass. And if it's a double contrast study or you use water-soluble contrast, your technique would be 90 kVp at 2 mass. You want to make sure the patient's lying flat on their back and straight. And your central ray, we're only going to look at if it's a stenic patient, because once you learn that, you can kind of everything else out. And remember, we should have been looking during the fluoro at the monitor to see where the stomach actually is. Am I seeing pelvis? Am I seeing diaphragm? Is it spread out more side to side, or is it a severe J hook and I'm all the way down by the bladder? Those are things you want to look for. So it says for a stenic patient, the central ray is at the level of L1, which is found midway between the xiphoid tip and the lower border of the ribs. Right? So it's to the level of L1, which is at the duodenal bulb. I call this, we use the W method, and there's no way to explain that with words, something that I will have to visually show you when we go in the lab and look at this positioning. Because it's abdomen, it is exposed on expiration, so take in a breath, blow it all out, hold it out, beep. And on this image, you have to demonstrate the entire stomach and the duodenum. And typically you will visualize the diaphragm and the lower lung fields so that if there is a hiatal hernia, you would be able to visualize that. Now, let's look at an actual image. When the patient is AP, remember the fundus fills with barium, the body and the pylorus tend to fill with air. Okay, so you've got the entire stomach and the duodenum demonstrated. The fundus is full of barium, and these are actually optimal exposure factors. This is an excellent diagnostic radiograph. You can see some of the barium still left in the esophagus as it's coming through. So this one, the patient's AP supine. This one is a Trendelenburg where they've lowered the table, but notice you still see the diaphragm up here, and we don't see any portion of the stomach protruding up through that diaphragm, which is good for the patient. After the AP, we do an LPO, and that is on page 485. Okay. Again, you probably have a 14 by 17, but now you're going to collimate some. There's no need to leave it wide open on the patient. It's not good practice to do that. So you always want to try and collimate to probably at least a 10 by 12, I would say. You will find in the field they don't collimate. They tend to leave everything wide open, and their argument is that the techniques are much lower now than they were, which might be valid, but there's still no reason to overexpose your patient unnecessarily. The technique doesn't change. It's still single contrast is 110 kVp at 2 mass. Double contrast or water soluble, you would use 90 kVp at 2 mass. All you do for this is rotate the patient from 30 to 60 degrees oblique. Now, why such a huge rotation? It's anywhere between 30 and 60. not your choice, but it's based on body habitus. The smaller the patient, like a hypo or astenic patient, are going to be closer to a 30-degree rotation, whereas a hyperstenic patient, like this patient they have in the picture, she's going to be more a 60-degree rotation. Why? What makes the difference? Well, typically when the body habitus is wider, remember, things tend to spread out. So in order to get an oblique view of that stomach, a wider patient would have to roll more to achieve the same results. Okay, again, looking at the positioning for a stenic patient, you're going to do what I call the W method, and you're still going to be centered to the level of L1, which is still found midway between the xiphoid tip. Midway between the xiphoid tip and the lower border of the ribs. All right. Now, again, that's hard to demonstrate without showing you, so I will show you that in the lab. It's also on those videos that are listed under the YouTube videos. You can see where I actually show you the W. And when I say W, it's using your two middle fingers and your thumbs to create a W. And you place, for this one, you put the middle finger of your left hand on the xiphoid process. You put the middle finger of your right hand on the lowest border of the ribs on the left side, and you just kind of lay your hands down, and where your thumbs touch, that's where your central ray goes. So watch that video and it'll make sense, and then I will show you in the lab if we are able. For this, you actually have to have the entire stomach and duodenum and an unobstructed view of the duodenal bulb. And again, because they're supine, the patient's fundus should be full of barium. So LPO, you can tell she's rotated because of the spine. It's not nice and square. It's actually got rotation. You can see ribs here. You can see that one side of the abdomen is elongated and not very much of the right side is showing. Fundus full of barium. You can see the remnants of the esophagus. Body and pylorus full of air going into the C-shaped duodenum. Okay, that's actually a good image. After the LPO, we do an RAO, and that imaging is actually on page 482. You're still on a 14/17, and if you have direct radiography, I would probably just leave the same collimation you had for the previous picture, because there's really no reason to change it unless your image showed that you clipped anatomy. The technique is still the same, 110 kVp at 2 mass for a single contrast study, 90 kVp at 2 for a double or a water soluble. Again, the degree of rotation, 40 to 70, has to do with getting the anatomy in the correct position. Typically, if it's a hyperstenic patient, it requires more rotation. Astenic patient, less rotation. As far as centering, you're still centering to the level of L1, and this is found midway between the spine and the upside lateral border of the abdomen. Okay, again, those videos are invaluable to watch, where I literally position every single one and I show you where that is and what I'm actually talking about. So if you haven't watched those videos, please make sure you do. It will make life so much easier. Now, since the patient is on their stomach, in this particular view, the fundus should be full of air and the body and the pylorus should be full of barium. For this particular view, the duodenal bulb is in profile, which is important when you're evaluating or critiquing your image. So you need the entire stomach and the duodenum. The body and the pylorus now are full of barium, and the fundus is full of air because remember, it sits superior and posterior. So with the patient on their stomach, air rises and actually fills the fundus. The duodenal bulb is in profile along with the C loop of the duodenum, and that's actually a great image. The last we do, so far we've done AP, LPO, RAO, and then we do a right lateral. And the right lateral is actually on page 484 of your book. This is the only image that will demonstrate the retrogastric space. Now, what is that? Retro means behind or backward, and gastric space would be the space behind the stomach. So this view is the only one that shows depth. If anything was present behind the stomach, whether it be a mass or a tumor, this is the only view that you would see that. Okay, so it's the only one that shows the retrogastric space. Again, I would probably leave my collimation the same as what I've been doing for the past 3 images. I'm sorry, the AP would be wide open, and then I would collimate on the LPO and the RAO, and I would leave it collimated for this lateral. Now notice the patient's a little bit thicker because she's on her side. So for this particular view, the technique goes up. If it's a single contrast, you're at 110 at 4 mass, so pretty much double what you were flat. If it's double or water soluble, it's 100 kVp at 4 mass. Okay. Patient lies on their side in a true lateral, meaning you want their hips and shoulders on top of one another. You want their knees and ankles to line up. You don't want any rotation in the shoulders or in the hips. And you will find most patients do not lay straight because it's not comfortable. They think they're laying straight, and then you adjust them and they're like, this isn't comfortable, but that's when they're actually lateral. I'll show you on the image how you can tell if they're lateral looking at their spine. The central ray on this is again to the level of L1, which is the lower border of the ribs and mid-coronal. I'm sorry, lower border of the ribs and then 1 to 1.5 inches anterior to mid-coronal, because the stomach's actually going to fall forward when it has barium in it. The spine, you can see the spine or vertebral bodies are nice and square, meaning the patient is in a perfect lateral. If there is any rotation, it would be evident in the spine. Retrogastric space right here. So anything going on behind the stomach, this is the only view that would show that. Okay, and notice regardless of the body habitus, the stomach is full of barium, which is very heavy and dense, so everything tends to fall forward. So we see the stomach, the duodenum, the retrogastric space, the vertebrae are in a true lateral perspective, and this is actually a good image. All right, so that concludes the lecture on an upper GI. Again, there are 4 views, 4 overhead views. There's 5 technically because you have to include the scout image, which is that image taken prior to giving the patient contrast media. Then the radiologist or fluoroscopist comes in, gives the patient the barium. They move around, both standing and lying on the table. They move around to coat everything, and pictures are taken during fluoroscopy. And then once the fluoroscopist is done, then we take what are called our overhead images, which are our AP, LPO, RAO, and right lateral. Those are the 4 images that are done for an upper GI series. And they're typically done in that order, because once the radiologist or fluoroscopist leaves the room, you usually have the patient lie on their back where it's most comfortable and do the AP, and then you roll them up to towards their left for the LPO, continue rolling them onto their stomach for the RAO, and then they roll up on their side in a right lateral. Once those images are done, you would check everything, and then assuming everything came out, you would get the patient up and let them go ahead and get dressed, and let them know that their doctor that ordered that exam will get those results typically within 24 to 48 hours. I will tell you, I did not mention it in the esophagram lecture, but there are always post instructions when a patient is drunk barium. What those post instructions are is, we talked about this in intro, they need to drink 8 to 10 glasses of water in addition to what they normally drink, because they're going to fight you and tell you they don't like to drink water. 8 to 10 glasses of water on top of what they normally drink until their stool returns to a normal color. Their stool will be white when the barium comes out, and depending on how much barium they had, that is a little unnerving for a patient, so try to warn them of that. We do need to let them know if they don't drink the water that the barium can harden in there like cement, and there is no way to get it out once it hardens other than with surgery. Okay, so very important whether they have an esophagram, an upper GI, a small bowel study, a BE, regardless, any type of contrast media ingestion, meaning they drank it, they have to follow up with water, lots of water until their system flushes all of that out. And for everybody, it's different. Some people that have really active bowels, drink a lot, tend to have a lot of fluids and have frequent bowel movements, probably won't take as long. Somebody that might drink a lot but has very infrequent bowel movements, maybe every couple days, 3-4 days, that's going to take a lot longer to get out of their system. Do not encourage them to take laxatives. Do not encourage them to increase their fiber. If they ask you those kinds of questions, you redirect them to their doctor that ordered that exam. All right, I will see you guys in the live discussion and we will talk about this. Have a good day.